Hello, my name is Dr. Donald Jurevich. I'm a professor of geriatrics at the University of North Dakota School of Medicine and Health Sciences. Today, I'd like to present the first part of Age-Friendly, What Matters. And our goals today are to assess what matters to drive patient-centered care and to recognize barriers to assessing what matters. The other two goals will be covered in the following sessions. So as you may know, the Institute for Healthcare Improvement developed this age-friendly framework to help transform health systems into better care for older adults. And it centers around 4 principles of assessment and management. These are all related to evidence-based geriatric medicine. The first one is what matters, and then medication, and then mentation and mobility. So here's a case study. 92-year-old female reports fatigue, loss of appetite, and a 5-pound weight loss with generalized body aches. Her husband passed away from COVID-19 3 months ago. The patient's daughter, who's with her at the clinic, thinks that her mother has long COVID. When asked about her health care goals, the patient simply states, "I don't know." So to better understand what matters to the patient, the next best course of action is to A, provide the Stanford letter to the doctor template, B, conduct a PHQ-9 depression screen, C, conduct a mini-cog screen, D, ask the daughter if she's the durable power of attorney. So I'd like you to select which one of these you think is the best answer to the next step in understanding what matters to the patient. So if you selected B, that would be the best choice because this person may have unresolved grief or the patient may have a depressive disorder. And so it's important to do further analysis because this is clearly a barrier to her describing what matters to her. She's unengaged and apathetic to the whole question of what her life goals may be. So that's why answer B would be the most correct answer. Of course, answer A would be okay in a sense that it would give the patient some direction, providing that she didn't have a mood disorder. But this would help provide additional information to the primary care provider. The mini-cog is also to be practiced, and it may be positive when somebody has depression, so it's hard to tell whether a positive screen would be a manifest of memory impairment. And then asking the daughter as a durable power of attorney is okay, but sometimes the family matters really complicate things, and you can already see from this case study that the patient daughter is trying to direct your thoughts as to what the clinical diagnosis may be, which is not always a good thing. So again, trying to remember that there are differences between older adults. There are some that are highly engaged, highly functional. They want to feel strong and as active as possible, as opposed to somebody who may have progressed into frailty and perhaps maybe pain alleviation or being cognitively lucid enough to converse with family and friends is the most important goal for that individual. And there's differences, right? In patients that are either highly invested, sometimes a little too invested, the ones that bring you the list of their blood pressures 4 or 5 times a day, daily. And then there are those individuals that have laissez-faire attitudes where they're just not as engaged and involved in their monitoring of their health care and probably less self-sufficient or low self-efficacy in terms of chronic disease management. So here's a quote: "The waning days of our lives are given over to treatments that addle our brains and sap our bodies for a sliver's chance of benefit." And all this is mentioned by L2 Gawande on Being Mortal, which is a remarkable identification of some of the things that we don't really pay attention to in the later years of our lifespan. So understanding that background, it's important to know and communicate our priorities. We have to identify what's most important to you. And we need to communicate these wishes to both family members and providers. This all promotes shared decision making. In identifying what matters to the older adult, it's important to align the care with their preferences. The older adult will specify some particular health outcome goals that may be perhaps a little bit of a surprise to the provider and to the family member. And it's important to realize that these healthcare goals are just not focused on what would happen if you become unconscious or were in a state where you couldn't speak for yourself. We want to know what the patient's wishes are in the end-of-life care. That's not the primary concern of what matters. So in defining healthcare outcome goals, we need to understand the values that are most important to the individual. And they may be, their goals may be hobbies and creativity. Perhaps they're highly spiritual and and are church-going folks that's their source of activity and strength. Some still may be working. I know that with increasing age, there's increasing retirement, but there's also re-entry into the workforce. Social engagement, being involved with friends and family, perhaps being physically active. Some people might be marathoners or senior Olympics, play tennis. The new one now is pickleball. More than likely, a lot of people are very interested in family relations. So these are all goals that need and influence the what matters equation. So care preferences often define what types of activities that the patients are willing and able, or conversely not willing or able to do and receive. That may be medication regimen, maybe there's too many pills, self-management tasks, maybe they don't want to weigh themselves every day, so you go to every other day or maybe twice a week or even once a week. Healthcare visits, how frequently do they want to see the provider? Do they get to the point of frailty where a home visit might be in order? And then also different types of screening tests and procedures all need to be considered as part of their care preferences. So there are impediments to understanding what matters. Certainly the providers, in a sense, don't always have time, as you can see in this somewhat disinterested older physician. And sometimes patients and families, they wait until an acute situation occurs, and then there's a mad scramble to try and figure out what the wishes are of the older adult patient. So there are pitfalls, and I'm kind of metaphorically put a rabbit hole here, and that always is the change in health status. So a sudden accident, a fall, traumatic brain injury, something that changes the physical status, perhaps a stroke. All of these really impinge upon identifying what matters from the get-go. Not that you can't address what matters moving forward when you have these sentinel events. It's just more difficult to do so. And then sometimes there's this incipient or insidious chronic change, such as Alzheimer's disease, and family members don't recognize it, and it really does have a problem with identifying what matters as the person becomes cognitively impaired. That doesn't mean that they can't make decisions or express preferences. It just becomes more difficult again. These are the impediments. Mentioned earlier, and again with the case report, about the additional impediments are patient ambivalence. They just really don't want to address the issue. And the other one is mood disorders, as illustrated by our case report, where the individual seemed both ambivalent and perhaps depressed. So part of the impediments to identifying what matters to older adults is that both providers and patients don't really understand how much remaining life expectancy they have, both in terms of active life expectancy and absolute life expectancy, which are not the same thing, and we'll see that shortly. There might be some cultural things. So older adults may not want to evoke the death spirit in a more general term, or they just may have concerns if they start talking about end-of-life issues that they may just fall into some bad luck with that issue. So here's some of the knowledge gaps that we can identify. So I mentioned earlier that there's a difference between active life expectancy, as you can see on the curve left, and absolute life expectancy. And pretty much it's 2 to 3 years between those two phases of life, no matter what the age group is. So it's a 2 to 3 year difference between loss of active life expectancy and death in a 65-year-old as much as it is in an 85-year-old. The other caveat is that older adults, I guess habitually or constantly, overestimate their life expectancy. And so studies have been done on multiple chronic conditions, and older adults always overestimate their lifespan by 5 to 6 years, as do their family members. So here's one of the examples of disconcordancy between patient prediction and reality. You can see that there's here, this is life expectancy, and you can see what the patients predict here as to how long they're going to live, and in reality this is how long they actually lived with New York Heart Class 4 heart failure. So some of the issues with the providers is that they'll often defer to the family and accept the family wishes over patient wishes. There's a study that showed that emergency-based care in one of the large institutions on the East Coast, that in the emergency room, basically 90% of all the advanced care directives were ignored. So in terms of the provider, and issues about what matters is that the provider doesn't always ask. They may not even look in the EMR, the electronic medical record, for advanced care plans. And also they just may be not cognizant of the lifespan and remaining life expectancy. So if you look, and I've seen this repeatedly, that documentation for the advanced care plan is usually less than 50% in healthcare systems. So we're not really doing a great job of identifying what matters and documented in our medical records. So part of the reason is that the medical complexity sort of puts a crimp on identifying what matters, because there may be on the right-hand side cognitive limitations that occur, and you can see that with increasing number of conditions, chronic conditions, that there's increasing amounts of cognitive impairment. So 1 out of 4 patients have some sort of cognitive fog or dementia when they have 5 or more chronic conditions. The Medicare approach basically encourages subspecialty care. And I did a kind of an ad hoc study on this and found that on average, patients that I've seen in my geriatric clinic had consulted 4 to 5 specialists, and they had twice as many specialty care visits as they did with primary care. So that's the fragmentation that occurs, and certainly the specialists are not prone to be asking about what matters to the older adult. So here we can see Mr. Spock, who passed away from COPD. He was a lifelong smoker. And it's important for providers to understand what are the functional trajectories, right? So with Alzheimer's disease, if there's an absolute lifespan of 12 years after the onset of the disease, we know that the functional changes occur on a regular pace in a linear fashion. And the question is, how do we estimate life expectancy? And we'll show you a few tools for that later in this series. It's also important in this process to assess decisional making capacity. Remember, we said that 1 out of 4 individuals over the age of 65 with 5 or more chronic conditions have cognitive impairment. So it's always important to assess decisional making capacity, and there are tools for doing so. So we want to look at what matters from a perspective of establishing some clear priorities, I think everybody's in agreement that we want to reduce care burden, and sometimes, I don't know how to say this, but you can have a patient go down the wrong pathway and increase care burden by acute interventions that were futile to begin with. So the other point is to better integrate care and across the continuum. So these are all lofty goals, but things that we need to be mindful of in designing a program that addresses what matters. So from a very pragmatic point of view, we have to look at and say, what can the patient actually do, and what's realistic, and balance that out with what's aspirational as to what the patient wants. And sometimes they really are a clash. I mean, I had a younger patient in a nursing home who lost vision in both eyes, and I asked him what his healthcare goals were, and he said to see again. So there was a little bit of a disconnect between his expectations and what was reality, and identifying that gap sometimes helps you redesign the healthcare plan to address those concerns. So I just wanted to point out that there's a website called Patient Priorities Care, and it walks you through the steps by which you can identify what the priority needs are or the goals of the patient, and then define a healthcare plan, and then to reassess that healthcare plan if it's not really meeting their goals. Like some people will say, I never want to go to a nursing home. Well, how do you put that into the framework when somebody seems to need that level of care? And then finally, to align the care, and that's really the most important point, is to align the care of the healthcare team with what the patient's preferences are. So I want to thank you for your attention in this short presentation on what matters. We have 2 more modules to cover with what matters. And to summarize, in this module we learned that there's differences between older adults and their preferences for healthcare goals, and we need to be mindful of those and direct them towards patient-centered care. We need to understand what the barriers are, including either apathy in the patient, or maybe overly involved family members or under-involved family members, as well as nuances for the healthcare system that's driven by acute care rather than preventative care. And most importantly, remember that there's a 2 to 3 year gap that's between active and absolute life expectancy. And so you'll know this when people start developing functional impairments, and that's usually the onset of the decline in active life expectancy. And then finally, remember to evaluate and manage what matters at each clinical counter, even if it's simply asking the patient, has there been any change in your advanced directives? Is there any change in your healthcare goals? So I want to thank you for your attention, and I appreciate your application of what matters to your everyday clinical practice.